are the backbone of our homes. But even in the workplace, women still face gender pay gaps. For example, even for the same level of work, it's been shown that women are paid less. So it's upon us to look into these issues and see how we can address gender inequities. And in relation to this, we want to have a presentation from Eunice Atsali. And so I'm going to welcome Eunice to make a presentation, and then Professor Obimbo will be able to lead the question and answer sessions. Welcome, Eunice.
Thanks, Doc. Okay. I don't know whether I'm audible enough.
Yes, I can hear you from my end.
Okay. I'll just begin. Yeah, my name is Eunice Atsali. I'm a midwife, a lecturer at Kenyatta University, but at the same time, I'm the National Secretary for Midwives Association of Kenya. Let me give a disclaimer. I'm not a gender expert, but then I am a scholar. So that means I keep on learning and also trying to figure out issues that are affecting women and especially in healthcare system. So today I'll be presenting a little bit about gender and task sharing, and let me give also a disclaimer that there'll be a lot of midwifery and nursing within this, but then of course with also our counterparts, obstetricians. And before I begin, I want to appreciate KOGS for allowing me to utilize this forum and also to be able to share my knowledge about gender and task sharing. And also I want to appreciate also the FIGO for also allowing me to be part of the training for LDI REACH program. So thank you so much, and we'll begin. So I think I'll just pick from where Dr. Elly Odongo started from on showing discrepancies in healthcare and also in leadership regarding women generally in leadership position. So I'll quickly just talk about what is gender equity. And I think it's a common knowledge for many of us here, but it's a song that is meant to be sung again and again. So gender equity means fairness, righteousness in distribution of benefits and responsibilities between two genders, regardless of any gender discrimination of man and woman. And gender inequality is not only a pressing moral and social issue, but also a critical economic challenge. And I think that's exactly what Dr. Elly just spoke about. So if women cannot achieve their full human economic potential, family well-being will continue to suffer on a global scale, because of course women constitute majority of gender per se. What are the common features of women's work generally? Women's work is usually invisible, undervalued, stereotyped, subject to prejudice, assigned to lower value than men's work. And I can give example of even our own mothers. They do quite a lot, which cannot be quantified in terms of how much they bring on the table. And midwifery is a predominantly female profession providing care to women, and as such is further undervalued, and that includes also nursing. So gender in global maternal, we have an example of how there is gender disparity in global maternal health. And as you can see this figure, it goes, the orange becomes deeper and longer as you go down. And in healthcare workforce, only about 12% are CEOs in healthcare. About 23% are at World Health Assembly heads of delegation. And then the majority fall within the working group, the healthcare workers in the working group. And this is where we have 80% who are nurses, and we talk about nurses and midwives in this case. So this is just an example of gender disparity. On a gender in global maternal snapshot of status quo still the same in 2022, Fortune 500 healthcare CEOs were only, that number that I showed earlier, 12%. And healthcare workers, many of them female, constitute about 80%. So when we talk about nurses and midwives, also there is a little bit of gender disparity there. We are talking of many of them being women, and that is about 99%. And only about 1% of nurses and midwives are men. So there is also a gender issue there. Why? Maybe because of the women work being undervalued and nursing and midwifery being considered as women work. However, on a flip side, when you look at the countries that are ruled by women when COVID-19 happened, like, for example, in New Zealand, where we have a female leader, the deaths in orange were much lesser than where men leaders were. Why? Maybe this is because women are better or maybe intuitive and they want to protect very fast. And maybe that's why they did well. Like, for example, in Germany, Angela Merkel's country, we had only less than 10% death from COVID. Bangladesh, the same. But when you look at countries that are ruled by men, then we wonder, why is it that then we are not trusting women at leadership position? So why does inequality exist, especially in healthcare? Sorry, I left the midwifery there. One, it's because of patriarchal society, where men are supposed to be like the heads. From the time we are young, our man is supposed to be the head and we are supposed to follow. Two, because of poverty. Poverty, why? Because it's already created. If I'm a woman and I'm earning less, then that means I have lesser income compared with the male. So that means my income will be less. Midwives are largely relegated to vulnerable employment, hence disturbing to the gender equilibrium. So for example, in the rural areas, you will find the health workers that are put there, especially level 2, which I would think even level 2 and 3 requires actually a doctor and a highly skilled person, because that's where you can prevent death easily. But then at the end of the day, that is where you'll find nurses and midwives being the leads in that particular area. The equilibrium also occurs because of violence at workplace, although it's a bit subtle and sometimes undermine the effort to achieve gender equity. So for example, when you are in boardrooms and you're campaigning for gender equity in workplaces, sometimes you'll find a lot of condescending statements that will put you down as a woman. So you will not be able to continue pushing the agenda unless now you put up the male aura so that you look like a male, a fighting male. And that's why most of the female, even who are at leadership position, you'll find them dressing so that they look like male for them to be respected. The other thing is an equal distribution of opportunities and education. Although this is changing rapidly in the country, it has not changed so much where male are being given, of course, opportunities. And if you have 2 children, you have a male and a female. Most of the time, if your resources are lesser, there is a high likelihood you will push the male to go forward, and then you put the woman to follow much later. The other thing is fewer social benefits. There is a lot of fewer social benefits when it comes to lower job groups and where midwifery belongs. Because even if you look at, for example, medical cover, you look at medical cover of healthcare providers or professionals who are at level 6, and those healthcare professionals who are at level 2. The health cover is quite different in most cases. So how do we address this inequality? One, invest in quantity and quality, not just in quantity. So we need to invest in health workforce planning, management and regulation, and in the work environment. So we need to have working health workforce data systems that will be able to highlight when there is discrepancy in equilibrium. Health workforce planning approaches that reflect the autonomy and professional scope of midwives and nurses, primary healthcare, especially in underserved areas, enabling and gender transformative work environments, which needs to come from the policies as well, and then effective regulatory system. We also need to invest in midwife-led improvement to sexual, reproductive, maternal, newborn, and adolescent health service delivery by ensuring there is communication and partnerships, collaborations within healthcare professionals. Midwife-led models of care has been shown to work. So why can't we embrace it as a country that there can be midwife-led care model that can actually avert maternal mortality? There needs to be optimized roles for the midwives. And I think that's where the discussions will come in today. And then we need to apply lessons from the COVID-19 as I've shown in the previous statistics. And then invest in high quality education and training for midwives so that we have high quality educators and trainers to be able to impact in healthcare systems. And then education and training institutions need also to be of high quality. Then we need to invest in midwifery leadership and governance. So creating senior midwife positions in healthcare systems. And one of the things maybe we will be pushing forward soon will be the post of a chief midwife within the country. So that at least at the MOH, we have the chief midwife and then we have the other directors to follow. Then strengthening institutional capacity for midwives to drive health policy advancement. So can task sharing improve collaboration? Because one of the things that we can do in healthcare has to be collaboration in any aspect so that we can be able to achieve the healthcare agenda in this country. So what is task sharing? It is rational redistribution of tasks among health workforce teams. Specific tasks are moved where appropriate from highly qualified health workers to health workers who have fewer qualifications to make more efficient use of the available human resource. So why task share? And I think there is a policy towards that within the country. So one, why do we task share? To address low human resource for health, then increase coverage of health services with limited human resource, address poor health resources of health, human resources of health retention, especially in rural and less developed areas. And I think that's where the agenda for POCAs and the likes come in. Reduce the burden of specific human resources, then to increase the efficiency of health service delivery. And then, of course, more preference to urban sector by health professionals causing health, workforce crisis, and inequality. So you find that most of the healthcare workforce that is highly skilled is more concentrated in urban areas and less in rural areas. So I think that's why we need task sharing, so that we are not disadvantaging, especially the population at rural areas. So how do we task share and task shift? So there's a difference between task sharing and task shifting. So when we talk about task shifting, we mean the task has been removed from one professional to another professional. But then when we talk about task sharing, it means it can be done by any of the healthcare professional without making the other one feel disadvantaged. So there is task shifting level 1, which is from level 0, from specialized physician to doctors. Level 1, from doctors to non-physician clinicians. And level 2, from non-physician clinicians to registered nurses and midwives. And then level 3, where we have between registered nurses and enrolled nurses, and also from nurses to nursing assistants and community healthcare workers. And then, of course, task shifting for expert patient shifting. So I just was reflecting about how has task sharing worked before in healthcare system. And one of the ways that is so recent that task sharing has really worked is in PPH management through emotive bundle, where as a midwife, when you encounter a client with PPH, you are able to begin from any phase. The only thing maybe you may have to do that you will require maybe a highly specialized person is when it comes to maybe repairs and maybe when you require hysterectomy. But otherwise, there is collaboration, even in prescription. Then prevention of mother-to-child transmission. I think that this has worked for over 2 decades. Then family planning, where midwives and nurses were not allowed to insert an implant, but currently they do. IUCD at the same time was not supposed to be inserted, but now it's inserted. We have many specialist clinical officer anesthesia, nurses and midwives anesthesia, and of course, POCAs, which is actually exciting that midwives can now do POCAs at primary healthcare facilities and point of care facilities without necessarily encountering hitches. So conclusion on task sharing and gender, interprofessional collaboration is key in managing gender equilibrium in healthcare system. And maybe just to highlight again, midwives are not just a part of healthcare system. They are key players in driving towards UHC and achieving SDG. And they are highly skilled to bring expertise, innovation, and compassion to women's health. So we support autonomy and control to women's leading to reduced interventions, lower risks, such as PPH, increased satisfaction, particularly in lower risk pregnancies and birth. And thank you very much. Thank you.
Thank you very much, Eunice, for the presentation. We'll just take a few minutes of questions and answers. I've not seen any on the chat box yet. And if you want to ask a question, I think you can raise a hand. And I believe that the host will be able to allow you to ask your question. Thank you. Professor Obimbo, before you leave, maybe you can make a comment.
Yes. Good evening, everyone. Thank you very much, Dr. Atsali, for such a wonderful presentation. Definitely, I think the inequalities and inequality in leadership, especially when it comes to gender issues, cannot be overemphasized. And I really appreciate your insight to this. I know it's a context that affects most institutions, most places, and we have something to learn from you in one way or the other. I probably would think, based on our context and the Kenya scenario, do you think the opportunities for women generally in leadership and in terms of being able to control, what do you think is the new paradigm? What's the new outlook that we should be charting to make sure that many women are involved and engaged and they receive some level of equal treatment at workplace and other places as it were? Eunice?
Thank you, Prof. I lost you at some point, but then I think I was able to pick the opportunities we have to encourage women in leadership positions. Although in Kenya, we've made a lot of strides, especially when it comes to constitution, by saying there has to be gender equity, especially the 70-30 rule. I think that's one of the ways that we've done well as a country. However, I think we have to do much more, especially involvement of women in policy development, so that we can have empowering policies at workplaces to ensure that women can be able to participate effectively, especially in healthcare system. And then the other thing is our workplaces. We need also to make them very empowering for the women, especially women of reproductive age, because we have many of them who go for maternity leave, and by the time they come back, opportunities have bypassed them. So what can we do as maybe healthcare workforce to ensure that these women, despite the fact they are on maternity leave or they've gone to give birth, they can continue developing wherever they are? Or when they come back to the healthcare system or workplaces, they are able to function effectively and optimally. So one of the ways that I think some institutions have put in place is, for example, putting breastfeeding rooms for women. And of course, there are also gender advocates within most of the departments, so that at least issues to do with gender are addressed effectively in workplaces. I hope I've answered. Thank you.
Thank you very much. That's a wonderful insight.
Yeah.
So thank you, Elly.
Thank you.
Thank you, Prof. I'm not seeing any other question. I'm going to, but I saw a hand raised. Andusi, Andrea. Andusi, are you able to unmute and ask your question?
Yes, mine was just complimenting the answer. I think I'm in agreement with what she said.
Okay, thanks, Andusi. Then there's a question from Bogori. Oh, it disappeared. Can you see it from your end? Yeah.
Yeah. Are there opportunities?
From Bogori Murugu.
So Bogori Murugu is asking, are there opportunities provided by partners and associations to empower women health workers in MNH field? Yes, there are several opportunities. So for example, recently we partnered with KOGS and had a training for leadership under FIGO. So yes, there is a training taking place for leadership within KOGS. It is on the KOGS platform. Dr. Elly, kindly.
Yes, that's right.
Yeah, so you can easily log in and then be able to navigate the leadership training. And then, of course, as an association, for example, Midwives Association of Kenya, we offer opportunities to showcase your capability. So it's a matter of yourself bringing yourself forward, especially you will be committed in some of the committees. And I know in KOGS, I think they have similar opportunities where they give opportunities for people to lead in the committees. I don't know whether that's the case.
Professor Obimbo can handle that.
Yeah.
Sorry, I just missed this last part of I think I froze a little.
Yeah, like in what sense have you provided opportunity for people to showcase their leadership skills in KOGS?
Right. I think that's a good question. It's work in progress, and definitely I think it's an issue of also mentorship, getting everyone involved in the quest for leadership, allowing full democracy to thrive. We also, in this aspect of making sure that the young people get engaged in leadership, and of course, over time, we've really been able to provide resources that are hosted on the website. I know the uptake hasn't been truly as expected, but I think these are the things that are work in progress. We got a lot to learn, and such kind of talks that we are hosting will give us more insight on how to better improve, how to better equip ourselves. But I think at some point we definitely going to get there where everyone gets involved and everyone feels part and parcel of KOGS, and they can have aspects of leadership going forward. So I think one or the other we've tried, but I think it's work in progress to get us in a better place.
Thank you, Prof. I'm not seeing any hand that is raised, so I think we want to bring this to an end, and we now know that within the maternal health space and obstetrics and gynecology, there is evidence that women in leadership have the ability to expand the health agendas. And well, therefore, it's good to address the issues that deal with inequities and inequalities in healthcare leadership, and to have an insight into the prevailing gender context, especially in our country. And because I'm not seeing any other hand raised or any other conversation on the chat box, I'd like to bring this to a close, and thank you very much for attending. Asanteni sana.
Yeah, thank you. Thank you so much for the opportunity, and God bless.
God bless.
Thank you.